presentation is by Dr. Sameera, Efficacy of Subthreshold Micropulse Laser Therapy in Chronic Central Serous Retinopathy.
Good evening all. Good evening all. I'll be presenting on efficacy of subthreshold micropulse laser for the treatment of chronic central serous retinopathy. Persistence of fluid more than 3 months in CSR causes permanent structural damage, pronounced loss of central vision. There is no gold standard treatment for chronic CSR. The options include conventional focal laser, PDT, intravitreal drugs like bevacizumab has been tried. So micropulse technology is a new modality which chops a continuous wave beam into a train of repetitive short pulses. Here the temperature rises below the threshold for coagulation and inner retina is not involved and laser lesions are confined to the RPE layer. A subfoveal or juxtafoveal leak precludes treatment with conventional laser, but micropulse technology permits confluent therapeutic applications to the entire area of CSR. So the purpose of our study was to assess the clinical efficacy of 577 nanometer micropulse laser for the treatment of chronic central serous retinopathy. This was a prospective study conducted between May 2016 to March 2017 in our institute. We have included all those patients with any age or sex with history of signs of non-resolving CSR lasting for more than 3 months. We have excluded those patients with history of exogenous corticosteroids, diabetic retinopathy, uveitis, any hereditary retinal or macular disease. The primary outcome was change in subretinal fluid height and central macular thickness, secondary outcome being change in best corrected visual acuity. So we have evaluated all the patients with visual acuity, slit lamp and fundus evaluation, SD-OCT, fundus autofluorescence, fluorescein angiography, enhanced depth imaging with the aid of spectralis HRA OCT system. 3 patients were on rifampicin for 12 weeks which showed no response. The parameters, we used AIOC2018 subthreshold micropulse laser system. The area centralis lens was used for the laser delivery. Parameters were individualized for every patient. The titration power which we sought was as a just visible reaction on the non-edematous retina temporal to the macula starting with 50 millivolts in continuous wave, and we have stepped up 10 millivolt till we get a just visible reaction. The mode was switched to the micropulse. The power was used in the treatment quadrupled from the titration power. Say for example, if you got a just visible reaction at 10 millivolt, we have quadrupled to 400 and we have done the laser. Confluent zero spacing high density shots were applied to the whole area of leakage in a 5x5 grid pattern derived from the pattern system. The patients were followed up at 1, 2 and 3 months and retreatment was done for those eyes with persistent leakage after 3 months. So coming to the results, we had 19 eyes of 17 patients, 15 males and 2 females. Mean age of presentation was 40.3 years, mean duration of leak 7 months. 8 eyes presented with focal leaks, of which 3 eyes had a smokestack, 5 eyes had ink blot pattern, 11 eyes, that is 58% presented with areas of diffuse leak. So the leakage side, we had 6 eyes with macular leaks, 8 with the extramacular leaks, and multiple leaks were seen in 5 eyes. Now, the mean SRF reduced from 340 microns to 38 microns by day 90 post micropulse laser, and mean CMT also improved from 428 to 268 microns. The mean best corrected visual acuity improved from 0.46 to 0.26, which was statistically significant. There was no evidence of any retinal or RP damage was seen on SD-OCT or FAF. Persistent submacular fluid was present in 3 eyes after 3 months, which were retreated. So in comparison to the other studies in the literature, our study of this CSR patient showed more of diffuse leakage pattern, that is 58%, which showed very good treatment response. And complete resolution of SRF was seen in 84% of the eyes. Partial resolution was seen in 3 eyes, that is 16% for 3 months, which we retreated. And complete resolution was achieved in all eyes at 5 months. So in our study, we used less power for a range of 240 to 480 millivolts. This could be attributed to the higher pigmentation in Indian eyes. The mean choroidal thickness was also thicker in all these patients. So few examples. This is case 1 32-year-old male with left eye 618 and N10. Persisting fluid more than 4 months, foveal leak you could see in the angiography. And post micropulse laser we could see the patient's vision has improved from 618 to 68, 66 and N6 by day 90 with complete resolution of SRF. Another case, 43-year-old male, right eye 660, N36, diffuse leaks. So you can see in autofluorescence DRPE changes on rifampicin 12 weeks, no response. We have literally painted the areas of all diffuse leaks, and by day 90, the visual acuity improved from 660 to 69 with complete resolution of SRF. Case 3, 36-year-old male with 660 and N36 with multiple leaks at macula. So this is the advantage of micropulse. In this patient, we have completely painted the entire macula, and by day 90, the visual acuity improved to 6/9 with resolution of SRF. So the limitations of our study, there was no control group, absence of a control group, and the relatively short follow-up time and lesser number of cases, difficulty of titrating the treatment without observing a visible reaction with a risk of under-treatment. And to conclude, micropulse helps in early resolution of SRF in chronic CSR without leaving any signs of laser-induced lesions. It is safe. It enables treatment closer to fovea or even fovea over extensive areas of RP decompensation. Retreatment over the same area as needed can be done. Beneficial for patients requiring early visual rehabilitation, and it is cost-effective and non-invasive. No financial interests. Thank you.
From all the data that's already available,
Sir,
what has your study shown that's new?
We had actually, like in our study, most of the studies have showed like focal leaks were very common, sir. And by 6 months they have showed complete resolution of study. But in our study, actually 58% that the diffuse leaks were pretty common, more common actually. And our studies, actually 84% has resolved completely. The SRF resolved completely by 3 months.
So all this has already been reported. Diffuse leaks have been reported to resolve. So you had a mixture of acute CSC and chronic CSC?
No, it's only for chronic CSR, not acute CSR. We have taken only chronic CSR.
But the picture in some of your cases with just one leak and the fundus images did not really suggest chronic CSR. They didn't have that sick RP.
So we have taken those cases where there was a leak actually which is persisting more than 3 months. So we won't be seeing the
Would that be your definition of chronic CSR? 3 months fluid persisting. Would that be a definition of chronic CSR?
That's what we have taken.
Okay, fine.
All right, yeah, thank you, sir.
And just out of interest, what was your duty cycle?
The duty cycle, I have done a duty cycle of 5%, sir.
Okay.
Okay.
Are there any incidents of recurrence?
We had actually 3 eyes, sir, with recurrence. In fact, we have retreated those 3 eyes, and by 5 months we could see that also have completely resolved. And we have, in fact, we have painted the entire macula for this patient again.
The question part of it is over. I have a suggestion for you. Try to do your thresholding under micropulse. If by chance the machine does not switch to the micropulse mode, when you've done your titration under conventional, you'll have a foveal burn at 480.
I had one patient with that, sir.
That's that is when you learn this.
Yes, sir. In fact, actually, it was not a foveal one because I have started, micropulse in our institute. So, in fact, I had because of the electricity connection suddenly.
Correct. That's exactly when it happens.
Yes, sir.
So when you restart a machine,
yes, sir,
or your resident has put the machine on for you, this is when it happens.
Yes, sir.
And it's happened to, I think, most of us now. That's why I've switched to doing micropulse. The thresholding is under micropulse.
Okay, sir.
So you are sure that the machine is on micropulse?
Usually what I do is that, sir, even if I'm doing it under threshold, after when I switch to micropulse, I always make sure that you just do a test burn even with the threshold. That's what I do right now, sir, in order to prevent that. Thank you, sir.